So, a very good evening, everybody. I'm Dr. Alapi Prajapati and I'm moderator for the day. I extend a very warm welcome to all of you to this episode of Women and Child Mental Health Subcommittee of Indian Psychiatric Society West Zone Branch, which is on the topic of mental health promotion in young. I think this topic is very unique and very crucial for this time. As we all know, early years are very important, very crucial for development. Uh, may it be physical, emotional, cognitive, and children get all the opportunities. But along with these opportunities, they also face some unique challenges and stressors, which are often overlooked and misunderstood. Today, we are going to discuss this topic at length because when we invest in the mental health of youngsters, we are investing in the future of our society. And today's session invites us to shift the lens from treatment to prevention, from crisis intervention to promotion of psychological well being. In an era of uh, the today's time where youngsters are facing unprecedented academic, social, personal, and even digital stressors and pressure, the need for upstream mental health promotion has never been so urgent. So, this goes beyond just diagnosing and treatment, and it involves empowering young minds by emotional literacy, by building resilience, and creating and fostering some environment which can help mental health wellness at every stage. And I'm very happy, very glad, and we are all honored to have Dr. Shivanand Kattimani sir with us as today's speaker. He was my guide when I did my postdoctoral fellowship in child and adolescent mental health at JIPMER, Pondicherry. I welcome you, sir. Uh, you don't.
Alapi, before we start, can we invite our President, Sir Dr. Bhave, to actually welcome all and say a few welcoming words?
Sure, ma'am. I welcome you, sir.
Yeah, yeah.
You have been the most enthusiastic person for these webinar series, sir. And under your guidance, we are able to manage and organize all these webinars. So please, sir, if you can put forward some words.
Yeah. Thank you, Alapi. It's again a great pleasure to be here today. I mean, being associated with this subcommittee has been a great pleasure for me for the past 6-7 months. And Alapi, though you credited me with the guidance, I think the real guide is Dr. Tambara, who's been so enthusiastic about, all that brainstorming that I see on the group and coming out with wonderful topics, guiding the whole team in a very good manner. Um, Today's topic, I was especially impressed. I mean, when I read about the topic, I mean, it's really impressive. I mean, when we talk of child psychiatry, it's more about problems and disorders and symptoms and the kind of future problems that the young generation is going to have. But we seldom talk of promoting mental health. I mean, there is so much that can be done by the parents, by the teachers, by mental health professionals who deal with children. And I'm very happy that a man of the eminence, experience of Dr. Kattimani, Shivanand Kattimani, is with us here today. It was a great pleasure for me for when I chatted with him for a few minutes just before this program began. So welcome, Dr. Shivanand. It's a great pleasure having you. And thanks for the kind words, Dr. Alapi. Thank you. Over to you.
Thank you. So I'd like to introduce you all to today's esteemed speaker, Dr. Shivanand Kattimani sir, who is currently Professor of Psychiatry at JIPMER, Pondicherry. He has done his MBBS from Bangalore and MD in Psychiatry from AIIMS, Delhi. And he has done his DM in Child and Adolescent Psychiatry from NIMHANS, Bangalore. He has extensive experience of teaching and learning in psychiatry. He has 25 completed MD dissertation as co-guide and guide. He has numerous indexed publications, and his areas of interest are mood disorder, suicide, and of course, child and adolescent mental health. He has a number of awards and recognitions on his name. He is currently working as head of the Department of Psychiatry at JIPMER. And also he is working as member of JIPMER Scientific Advisory Committee, JSAC, worked as Associate Dean Research at JIPMER. He has been reviewer for many psychiatric journals, and also he has been the academic editor of PLOSON. I welcome you, sir.
Yeah, thank you, Dr. Alapi.
Sir, you are going to share your screen, sir?
Yeah, I would like to share my screen.
Okay, I'm stopping screen share.
Just a second, bear with me, just trying to share. Okay. Is it visible?
No, sir.
No,
Not
not
yet, sir.
Not yet. Okay. Yeah, it will be visible now. Just, is it visible now?
Yes, sir.
Yes.
I think yes. It should. Let me move this thing. Yeah, it's in full screen mode.
Yes, sir.
First of all, this is a little bit odd hours. Thank you very much, the vibrant and rich West Zone of Indian Psychiatric Society. This president and then their executive team, Professor Mehta, they're doing a very wonderful job. It's very difficult to organize an audience at this time, but instead of more than a quantity, I believe in quality. Even few people are there. I like to share my few ideas with this audience. And bear with me if there are some disruptions because the network area in my nearby area is very poor. I hope I'm audible and clear.
Yes, sir.
Yeah, okay. Thank you. The topic I've chosen is a little different. It is not a one which attracts everyone. If you have something for exam related or something, then people would have attended like anything, PGs especially. So this is a little different. Before I start my topic, which is going to last for around 30 minutes, and I would like to keep more time for discussion and question answers. And all these years of my tenure in psychiatry, I've never been a good speaker. I'm a good listener. Last in Hyderabad, I listened to Professor Bhave's talk as a part of symposium in spirituality. I was one of the audience in the group. So this task has been given to me, so I will try to do and on this topic. Before I proceed, also my deepest condolences for the tragedy that happened in Gujarat, Ahmedabad, and many of my seniors who have studied in BJ Medical College, and also my colleagues have studied there from the BJ Medical College. And my heartfelt condolences to all those people who have lost their lives and their families. My topic is on mental health promotion in young. So what we are going to achieve in this next 30 minutes is that few things only, that idea I would like to share. One is about the prevention promotion. Can it be applied in the children and adolescents? 20 years back, if you ask me whether can we talk about prevention and mental health, I would have laughed. But there are rounds about going on about prevention. People are talking it long back. Even Professor Dilip Jaste, who is once a president of American Psychiatric Association, has written many articles on prevention of mental health illnesses. So we'll know about what are the risk factors and protective factors that have been evidence-based, and are there any intervention that can promote and also prevent mental illnesses in young children. We all know the definition of health. It's not just absence, but being physically and mentally fit and also being socially productive. And this definition has been given just before even many of us were born. But apart from these three dimensions, fourth dimension is also added, and that fourth dimension is spirituality. So we all know that we cannot lead a life without stress. And this is a landmark study that has been done in a car factory, which showed that with increasing stress, there is increase in productivity, and with this stress is known as a eustress or a good stress. When it becomes too much, it becomes deteriorating. It's called a distress, and this known as a Dodson law. So the stress is a part of life, and stress is some sort of stress is useful in increasing the productivity. The other concept that we derive is that it's applied to non-communicable diseases, but can also be applied for even communicable diseases. About a model, a biopsychosocial model of George Engel, where he says that in starting of any illness, there is a biological vulnerability, there are psychological makeup that leads to that, and also there is a social or environmental context that can increase the risk of developing an illness. When it comes to mental illness, we need to clearly about what is mental health and mental illness. Mental health is that which need to be protected or supported, and mental illness is when something disrupts the mental state, how we feel, think, communicate, and behave. And we all know that psychiatry is a branch of medicine, and it deals with the diagnosis, treatment, and also prevention. It is there in the definition, but we usually do not pay much attention to the prevention. When a mental illness, it disrupts, we all know that about the thinking, feeling, and behavior to such an extent it causes a disruption and dysfunction in everyday life. We have defined all the existing mental illnesses as a common mental disorders and then severe mental illnesses. Common, they might be called as a common. I don't know. Let the audience might answer to this question. That it could be that it is so prevalent that it's very difficult to detect, or it is so commonly merged with the common day-to-day life affairs that it's very difficult to cut off whether it is a depression or a normal reaction. So these are the common mental disorders. These are the common ones, and most common among these is phobias. And there are, of course, there are severe mental illnesses characterized by recurrence and severe dysfunction like bipolar disorder and schizophrenia. And we all have various surveys and epidemiology that say that around anxiety is the most common one, followed by mood disorders and substance use. If you pertain only to children and adolescents, this is from the one city in America, but same thing applies to all over the world and including India. What it says is that almost half of all adult mental health problems or conditions start before the age of 14 years. That is why we need to focus on children. If you want to have a decrease, a prevalence of mental illnesses in the entire population, we need to focus on younger children. And out of these, only 20%, maybe in India, less than 10% will get any treatment. In India, we should remember that 40% of our entire population is below 18 years. It's a young population. And 6 to 23% of the mental health problems are found in children and adolescents. Among the substance, if you see here, but different age cutoffs, among the young, the blue color, focus on blue color, 12 to 17 years, we see that not alcohol, but marijuana is, or ganja or cannabis is very common. This is Western literature data. And then we focus on what is known inhalants. Inhalants are also very more common among this age group. How do we establish psychiatric diagnosis? We use either the DSM-5 or ICD-10. Now the ICD-11 has come. The criteria, consensus criteria are diagnostic criteria we use to establish a diagnosis. And we do not have any laboratory investigations. When it comes to children and adolescent population, 20% of the world population is less than 18 years. And 2/3 of this is in the low and middle income countries. And again, I'm stressing this take-home message from this PowerPoint is that 50% of all the mental illnesses start prior to the age of 14 years. Though two-thirds of the young population lives in low and middle income countries, but whatever the evidence is, research is, comes two-thirds of it comes from the Western countries. That is one of the paradox. We have different ways of, there's no consensus on dividing the age groups within the minors. So early childhood can be between 0 to 5 years, where early interventions are required. One example is including about the identification and the early intervention for autism and ADHD. School-going children are around between 6 to 12 years, where there is a parental intervention, parenting tips are more important. While for adolescents 12 to 18 years, teachers, peer, media, based and led interventions are more important. For youth, independent living and coping skills might be important. Here, when you see a child who has brought in 0 to 5 years, there is no direct counseling for the children, but it's a parenting tips that are which are required. This is the another model. It's called the ecological model. It's very important in when you go through the child and adolescent psychiatric training. What it says that the child development is based not on the parents, but also on its not only its birth history, but on parents, but on the neighborhood, schools, and also what makes up the existing culture and government policies and laws existing at that time. I'll come back to this why it's important. So let us focus on mental health problems. So mental health problems, we all know the same thing that happens in adults can also happen in children and adolescent group. So most common ones are the anxiety disorders, depression, substance abuse, and suicide. Apart from this, we are also not able to classify anywhere. We call them as a behavior problems, learning difficulties, high risk taking behavior, and suicide. One of the training deficiency is that in psychiatry, we are trained to diagnose the presence of mental illness. And if it is there, then to do treatment. But there are large population of young population who do not have a mental illness, but have some mental distress or some problem, some difficulties. But where it is a training in psychiatry lags there, we are not able to address those. We only know whether the mental illness is there or not, and what to do if there is a mental illness is there. So they also do have high risk taking behavior, and suicide is one of the common among this age group. Among anxiety disorders in young children, we know that social anxiety disorder, school absenteeism, performance anxiety, and decreased quality of life are possible. Substance use starts early with the gateway drugs, and it can lead to an increase in other mental illnesses. Depression is very common, but it goes undetected, uncared for, invisible, and there's limited participation, limited opportunity for young children. Suicide is the top 3 leading cause of death among 15 to 24 years, and it is a public health problem. And in America, in this age group, more people in this age group die by suicide rather than by killed by somebody else. So this is what it says, the importance of suicide among the age group. But however, when the people, students or young children are affected, how do they think about mental ill? What is their attitude? This survey shows that the young people, you think that those means who are having a mental illness are dangerous, or they have unpredictable belief, and they think that if there's somebody with a mental illness goes to anywhere, they will be forcibly locked up or given electroshock treatment, or there is no treatment. Almost 45% youth believe this, and they believe that recovery is not possible. Almost 70% of the youth believe. So this attitude, negative attitude, makes them very less likely to approach and go and seek help, and they may be lost in the pathways of care. Now coming to the risk and protective factors for mental illness, to answer, we have identified that there can be individual level risk factors and at the same time individual level protective factors. This has come from the various studies, and in this we have to identify those which are modifiable, which can be useful for intervention, like head injury and childhood exposure to lead and mercury. This can be early substance use can be prevented by environmental modifications. Protective factors, we need to enhance them. At the same time, there are many risk factors at family level and also at protective factors. We should know what are the risk factors and what are the protective factors. Especially among the family, the protective factors preventing from mental illness even a family meal together with children, it in the long term has found to decrease the chance of development of anxiety disorders. So a simple ritual, a simple meal of family together can go on decreasing the risk for anxiety disorders. The among protective factors among family could be family which provides a structure and has a limits, rules and monitoring, and put certain expectation on behavior and values of children. And there is a support relationship within the family members is there. It is a protective factor. There are also neighborhood and school community that also are lead to an increased risk or can also decrease the risk of development of mental illness among children and adolescents. Among the protective factors, if there are good mentors are there, if there is a support for development of skills and interests, and if there is a provided opportunity for engagement of school and communities can also lead to protective factors. So this whenever there is a risk and protective factors imbalance happens, it will affect the school performance, lead to deviant behavior, physical health, and increase the risk for suicide attempts. Among this, definitely they will, because this made compulsory to be in a school till the age of 14 years, it might lead to some school discipline action, school absenteeism. If they're too much worried and anxious about their performance, I'll have learning difficulties. It leads to problems within family and risk of getting into juvenile justice system as children in conflict with law are getting taken care by child welfare committees. So this is this shouldn't come to this stage. Mental health interventions on the young. Among the mental health interventions, we can speak at different levels. This is a pyramid where it shows that there are large population among the children and young population which may benefit from universal preventive interventions, and there are a selective preventive interventions for another chunk, and the smaller chunk requires indicated preventive interventions. The last portion is the treatment, and our entire training goes in the only providing for a small chunk of this. The last portion, the blue color, is treatment, but large population which requires universal preventive interventions gets unnoticed and uncared for. The universal preventive interventions are those for the led at the general public that have not been identified even at risk. For example, mental health and substance abuse curriculum in all children at school can be developed. So this can help as a overall for all the children, it can help as a preventive measure. For selective preventive interventions are those targeted at children subgroup who exhibit either vulnerability because of the biological, psychological, or social risk factors known to be associated with the onset of mental and emotional behavioral disorders. For example, having an support group for children exposed to domestic violence, or children exposed to a traumatic event, or substance abuse at home. So this constitutes what is known as selective preventive intervention. There are subgroup of children who are already showing some symptoms or deviant behavior or early into the substance abuse, but not at fully developed a mental illness. So this is a small chunk which requires indicated or preventive interventions which can be delivered by counselors or specialists in the school. This is called as indicated preventive intervention. The interventions is for high risk individuals having some detectable signs and symptoms, and also there is a biological predisposition to such disorder, but do not meet at this time diagnosis of a mental illness as per our diagnostic criteria at the current time. For example, programs to develop social skills and coping mechanisms for children and youth who have been referred are being in the truancy or substance abuse in the early. There is a small chunk, of course, which are brought to our centers or to other any mental health facility for treatment. So these are the ones which require intervention, who have a diagnosable disorder and intended to cure or reduce. That's the target. And we all know all the childhood conditions do not have approved medications. Most probably we might have to do a non-pharmacological interventions for these people. So overall, what this interventions preventive can be universal, which focus on a larger population but requires more investment, but it will lead to better returns in the long term. There are selective preventive interventions only for a focus group at a high risk group, and indicated those at children who are showing some one or two symptoms, and then not a developed mental illness and substance abuse dependence, and these require interventions. And of course, the last one who have already developed some mental illness and can be diagnosable and require treatment. This is in a longitudinal, in a lifespan pattern. This is where we can have a intervention at different levels. These have been evidence based. It has been proven actually. Prior to conception, also you can start intervention. Like there are young women who are become pregnant, who are not educated, who are using substance use, and then who are in a high risk neighborhood. When they are given a proper care during pregnancy, and there's a nurse who are attached to them and can provide care and also prepare them for a childbirth, provide good maternal and child services, and also tell them about how to care for a newborn child. So this has found to reduce for the children future the risk of going into delinquency or any substance abuse early. In the prenatal care and home visiting care also goes in a long way in a vulnerable population, not for everyone. Those who are having poverty, those who come from the adverse environment or a bad environment, neighborhood. So prevention of early childhood in, adversities, parenting skills when it comes to childhood, and this parenting skills we never required it, but it is coming essential because we're nuclear families, and both parents, if they're working, there can be differences. They don't know how to bring up a child, and they do not have any grandparents to guide them. And social and behavior skills training and the classroom-based interventions. Early adolescents and adolescents, we can have a preventive model for depression and prevention of schizophrenia also being tried. There can be community-based interventions, school-based interventions, or there can be major changes in the policy levels. Preventive interventions, are there any evidence-based preventive interventions? If I talk about India, the universal examples for universal preventive interventions are, the best example is our Anganwadi ICDS program, which provides nutritious food and also provides preschool educational opportunities, and also it screens a woman for early any deficiencies or for health of their maternal care. Rashtriya Bala Swasthya Karyakram is another program, and Rashtriya Kishore Swasthya Karyakram, which focuses especially on adolescents on their health and reproductive health, and also focus on their mental health through peer counseling. Of course, this has not been adopted everywhere in all over the states, but it's a good initiative. Selective for those at a high risk, there's a high risk reduction and resilience enhancing approaches. Interventions are being tried, targeted towards parents. Even poster parenting, that parenting tips are given and how to take care of the adopted child. CBT and psychoeducation and family therapy skills training interventions are being tried. There are small chunk which requires indicated interventions. These are being tried for those with a subclinical externalizing behavior in the form of resilience enhancement, cognitive behavior therapy-based intervention, and psychoeducational interventions. There are small chunk which requires definitely treatment. Remember that only few studies that have generated evidence come from the low and middle income countries. As I stated again, I would like to highlight that 2/3 of all children and adolescent population is with the low and middle income countries. The evidence needs to be generated in the low and middle income countries from the methods that are applicable and useful and replicable in our society and cultural acceptable. That interventions, in particularly when I looked for preventive interventions that are done in India, there are a few studies that are school-based, mainly uses the life skills education and coping skills and resilience curricula. I'm not going to go in details. Definitely there are some school counselors and NGOs which are interested and mainly focusing on schools. There are community-based interventions, mainly focusing on fear education and reproductive health information. There are digital-based interventions are now coming up because most of the people are using a hook onto digital media, and then there's need to be an awareness, and digital media can also be used as an intervention method. Blended problem solving game-based interventions are being also tried, but the evidence generated is very poor. For this evolving the new generation Z, there we will definitely face more challenges. There is a more need for evidence-based interventions. That's the current status as in India. Among school-based interventions, apart from that, what I have already stated the studies, they are focusing mainly on as a universal method, building up positive mental health, building a well-being, and decreasing the negative mental health, especially depression, anxiety, and psychological distress, and focusing more on academic, social functioning, especially on preventive aspects and bullying and decreasing their behavior destruction. To conclude, that we need to adopt a healthy lifestyle patterns, and that involves exercise is a good way of decreasing long term decreasing the risk of dementia, but also in increasing attention focus for children, and also decrease ADHD symptoms. We need to develop models on developing positive coping. Problem solving, interpersonal skills, these need to be taught. WHO has given a WHO life skills, and how even CBSE gives a guidelines on how it should be implemented. Teachers among the CBSE schools, one or two of them are nominated to get trained in life skills so that they can deliver it for their children, for their school students. Protective and supportive environments need to be built at a family level, at school level, and at the wider community through policy changes. Mental health can be promoted through early childhood interventions. This is just I'm bringing about the crux of this presentation, by making home visits for a high-risk pregnant woman, and preschool psychosocial activities can be taken up. Providing support for children in the form of parenting tips, skills building programs, child and youth development programs. They need to be involved in more of recreational activities apart from studies also. Programs targeted especially vulnerable groups. These vulnerable groups includes the minorities, indigenous people, migrants, and people affected by conflicts and disasters. And incorporating mental health promotional activities definitely need to be included in the schools by involving into making them more child friendly. And we need to adopt anti-bullying measures and life skills training. Some of the measures about adverse childhood experiences. This is the one scale which is widely used, given by WHO, which gives almost around 13 events. I have not included all the events here. This is a screenshot of a few events, which will help you to identify the important adverse childhood experiences that are experienced. What literature suggests is that there are 13, there can be more than that, but WHO has compiled and made these are the 13 events that includes also physical abuse, emotional abuse, and sexual abuse, and also includes even witnessing domestic violence or even a community violence. Among these, if almost 80-90% would have experienced some one adverse childhood experience during their childhood. It's very common. Even we have faced this. But whenever more than four or more than adverse childhood experience are experienced before the age of 18 years, that increase the risk of development of a mental health problem in a future life as adult. Not only the adversities matter, but what matters is that the children also undergo beneficial or good childhood experiences. This is the latest thing that is coming up. We have till now, we have only focusing on adversities in childhood that as a risk factors or vulnerability. But they say that children can also have some positive experiences that determines, that helps them in coping and building resilience, and also prevents them developing a mental health problems. There is a 20 list made by Narayana et al. From USA, and these are called benevolent childhood experiences. So we need to predict a balance between the adversities, experiences, and positive experiences, which we usually tend to neglect, that help us to know whether it is at a risk of developing mental health problem or not. So when it comes to the final one, stress and performance, we all accept that there cannot be a life without stress. Stress is a part of the life. And when I take this, usually a class on stress management for undergraduate MBBS students, usually the question they ask is that, can you have Can you tell me what is that stress that can increase my productivity, but do not deteriorate my productivity? The answer is no, we cannot have that. Each individual's coping and stretching capacity, resilience capacity is different. So we cannot have this is the stress optimal that can be given for everyone. So each individual is different. And coming to that, we need to develop evidence-based programs for preventive measures for our low and middle income countries, especially Asian countries. We need to develop early intervention services for children and adolescents. And we still have a lack definite reference processes from school to the hospital setup and from family to the hospital setup. And school-based multi-component programs are definitely required. And this is probably one of the last slide, that if George Angel's model is very well validated, and if there is a biological vulnerability, psychological makeup, and social factors that determine the onset of an illness, like a mental illness, and these can also be used for treating or preventing mental illnesses, biological methods, psychological methods, and social environmental factors. And I'll come to this important why it's important. When this ecological model, what it stresses is that if you need to prevent, my task is not to focus only on the child. We need to focus on their parents, parents drug abuse, parents employment, quality of family, then good schools, good neighborhood. It's where concept of green neighborhood is coming, green spaces, and then the decrease in criminality and access to health and care for everyone. Then we need to have a better culture and religious institutes and the government policy and laws that can support this. So that's why I say these two are important: the stress and outcome, and also the brand friendness ecological model. With this, I would like to end here. Once again, I thank the West Zone of IPS for giving me this opportunity.
Thank you, sir. It was very insightful, I must say. And actually, sir has planned to put some questions to make it more interactive for audience. So I think the support team staff can just post that poll, and everyone from audience can answer the questions. So, okay, first question is, among the following, which is not considered an adverse childhood experience according to Adverse Childhood Experiences International Questionnaire ACE IQ? I think the question is visible, right, to everybody?
Yeah, this fall is visible. I can see, but how to vote this thing? It's saying get a QR code. Okay, they are voting. Okay, fine. I can see the votes. Yeah, correct. You can also interpret.
Yes, sir. So, sir, how much time should we give?
Yeah, give at least under the 10 seconds.
Okay. Okay. So, we are getting answers from audience. And okay, so 8 participants have already answered the question. Sir, should I go ahead with the answer? Right answer?
Yeah, still there almost under 5 seconds, probably.
Okay, sir. Okay, sir.
I cannot, I think, vote. I think that is the thing. I think others will be able to vote.
Yes, sir. Second question is, which among the following is not a benevolent child experience before the age of 18 years? And third question is, who introduced the ecological model and its influence on child development?
Yeah, I think from the votes that are available, I think it's pretty clear that they are well attentive and they already had a previous knowledge about all these things. Except the third question, there is some confusion. Third is votes are divided.
Yes, sir.
While they're giving votes, you take entire time and end. One of the thing when I was presenting this, one of the audience asked me, this adverse events or experiences, we adults also face actually. Then why focus on only children? The answer is that the children have a developing brain. The maturation happens till the age of 21 years. Though at 18 doesn't mean that after 18 years and the overnight they become adults. So when the growing brain is affected at early age, so it will have an effect on the entire lifetime, whether it's a good experiences or bad experiences. So that's what we are focusing on all these experiences before the age of 18 years. So all adverse experiences are positive experiences. We focus only on whether they had this before the age of 18 years. They might continue to have even after the age of 18 years, but the below 18 years is important. Yeah,
Sir,
we
I
can
was
stop
wondering-
the problem.
Okay. So, sir, should I give the correct answers?
Yeah, give the correct answer.
So, correct answer to question one is everybody is correct, I think. Living in rented house is definitely is not considered as an adverse childhood experience, according to the questionnaire. The correct answer to the second question is most of have been correct. That is option C, sleeping at irregular timing at night, which is not a benevolent childhood experience. All others are benevolent childhood experiences before age 18. And then the last question, I think the name itself is difficult to pronounce. It is Bronfenbrenner who introduced the ecological model and its influence on childhood development. And actually, sir, during my fellowship, I came across this ecological model, and I think it is very beautifully described. Because even clinically, this is very important. When we come across children, it is very important to see the psychosocial background, not just the child, but everyone else who is involved in the child care. And most of the problems start with the environment itself. So it is a very beautiful model. We have some comments in the chat box. So wonderful slides, sir, says Neha Salankar, ma'am. Then excellent concept teaching, sir.
Yeah, it was really very lucid and very detailed, and the slides were really very good, sir. Thank you, sir. But I have just, as you are working more in this area, and we for almost these 30 years, we have done many things like through district programs and school mental health programs. We have done school programs for parenting, etc. We have done programs with parents, etc. Sir. And I have also closely being in government seen this system of Anganwadi workers. We've trained all these people, but with all these efforts and all, at least I feel that we are not doing enough. So do you also feel that how much more we need to do, sir? Because as such we observe that the mental health problems are increasing, at least they come to us much more. And I feel that there is how to bring the sustainability of all these programs, because the main challenges are that the manpower changes, people change, and what exactly whatever we train, but ultimately what transpires at the grassroots level, that is always a question, sir.
Yeah, these are, Madam, thank you. Thank you once again, the IPS President and Executive Committee for inviting me. I see that in audience, many of my known people are there. Thanks for your comments. And Dr. Ankita Patel is there. I know her. I think she was there with us in the NIMANS for training period. Yes, these are very thought-provoking questions. I'm not the right person to answer. Definitely, I agree. But treating individual person and it is more highly investing, but with less product output. And people have done actually the cost effectiveness and input output, and they have shown that the preventive measures require larger time and effort, but in the long term they yield a lot. The yield is very high. Like it is putting a seed upon fruit. You have to put, you have to wait for many years to it's have the bear the fruits. So that's how it model goes. I think being India is a large country, it's difficult, but ICT is one of the proven, well-known, nutritious and then early learning school exposure. It's a very good, successful model, madam. And other thing I talked about, more people should get into research and involve and then get evidence that it works or not works. Where everything we're
Yes.
asking from the Western countries, that is not right, I believe.
Over last a decade or so, what I see is actually more of pediatricians are going into a lot of preventive, promotive, work rather than the psychiatrists. I think we all also must try more.
Yeah, give me just this thing. I usually with my colleagues, we have this thing that we fight actually for this is my domain, your domain.
There is no fight. I think we must work in tandem.
Yes, that should we should go together. In fact, I said that a child psychiatrist should be open for pediatricians. In fact,
Yes,
we in Japan we have a collaboration between pediatrics and psychiatry that we run the child guidance clinic. It has been there long time before I joined. It has been doing wonderfully. And one of the many of the pediatricians who have trained in a child guidance clinic after their exposure, many have taken their developmental, I think, certificate course in CMC Vellore. So
yes.
they are interested, they pursue that. I think we should both work together. And pediatricians are large in number. We should make use of them, and we should have a collaborative work. I think for children's sake, for future of the nation.
Definitely. Thank you. Any others? I see so many of our subcommittee members, if anyone, and others also. If you have any comments or questions.
Sir, you mentioned this questionnaire, adverse childhood experience and benevolent experiences. So, are they available freely or they are copyrighted?
Yeah, these are available. Adverse childhood experiences in the from WHO IQ International Questionnaire is available on the WHO website. Even translated to different languages also available. Then benevolent is also in the public domain. The author from the one university, they made it public, and it's one of the wonderful tool I believe to assess both. And in fact, under the IPS, we are planning to do assess in both. What it says is that adverse childhood experiences, when anybody gets more than 4 or more adverse childhood experiences, as adult, there are increased risk of developing any communicable disease that includes substance abuse, mental depression, psychosis, cancers. That's what it is, the evidence is showing. So that's what we have to reduce that. We have to reduce that having significant adverse childhood experiences. And now we have found that what to do only with adversities. We have found that there are childhood good experiences. I call benevolent means beneficial or good experiences. As an individual, we can be a good peer or a good teacher or a good adult for a child. Or you can ask is school engagement and preventing bullying or something that goes in a long way. I will, Madam said, ask na, how it's nothing, what you're doing is not enough. But I think I believe in atomic habits, 1%. Change in 1%. I think if we can all change in a little bit of 1%, it will yield a lot of good in the long term, both in the public domain.
Thank you, sir. I think we don't have any questions in the chat box.
Yeah, no problem. Anyhow, I'm available. You can this thing. So
Dr.
we'll be happy.
Bhave is still there if he has any comments or any suggestions. No? Dr. Nilima, Dr. Neha. Okay, then if there are no more comments or experiences, sir, if you can share some anecdote or some experience that you have really worked and how it has helped or you have perceived it has helped, if you want to share, sir.
Not much because our working styles are different. We are only working in a hospital based. Now only recently we have started becoming, after becoming a professor, started engaging with NGOs who are working in the community, like Trust for Youth and Child Development is there. So from where we are learning, and we are also collaborating with the community medicine, and where actually, in fact, if you see RBSK and other things, they actually want schools to be actively involved. They want to attach with the UHC and the PHCs, urban health
Yes.
center, primary health centers. So that's where we want to make an impact there. If
Have
you have
you made
experience, you can
have you
share.
made any module or something like that, sir, like life skills education? And we also have tried implementing, and whoever the schools invite, we do these programs there. And yes, but over time, as I said, sustainability for us, because we are busy with all our clinical work, that becomes difficult. And otherwise, also, as you said, there's hardly any research, and that too this requires a long term research. I mean, we can't say that immediate effect. So we have to do a research, and maybe spanning over years, so that becomes a big challenge as such.
Yes, I think the next generation will take up that challenge. We only have to make
let's
sure there is a
let's
deficiency. What
hope.
is say?
Sure, sir. Thank you very much. Okay, Alapi, if there are no more questions, then we can wind up.
Sure, ma'am. So let's come to the conclusion of this very enriching and insightful discussion. I would like to deliver a vote of thanks on behalf of our subcommittee. So first and foremost, I extend our deepest gratitude to Dr. Sudhir Bhave, sir, to constantly be there, for being so encouraging and inspiring. A heartfelt thanks to our distinguished esteemed speaker of today's webinar session, Dr. Shivanand Kattimani, sir, for sharing your knowledge, your clinical expertise with us. And of course, the question answer session was incredibly informative and engaging. The question poll, and that offered us new perspective and ideas on prevention aspect of mental health, and not just the diagnosing and treatment aspect of mental health in young. So thank you, sir. Thank you to the chairperson of our subcommittee, Dr. Ritamra ma'am, for always guiding us and supporting us all throughout the preparation of this webinar series, and all other team members of the subcommittee for their tireless effort and work behind the scene to ensure the smooth execution of this webinar. A special thanks to our enthusiastic audience for joining us today. We are truly grateful for your time and engagement. And lastly, I would like to thank to our support team for making this webinar very smooth. Have a great evening to you all. Thank you.